Similarly, it becomes much more easier to abduct your arm. So, what happens in case of a tough arthropathic shoulder? Because there is superior migration of the humeral head, the F component or the deltoid force component is decreased, and hence abduction becomes very difficult. Plus, there is no supraspinatus or infraspinatus helping the abduction. This is what we strive to achieve in case of reverse shoulder, where we increase this distance and this distance, meaning we medialize the center of rotation of the whole system and we try to distalize the humerus, thus increasing the F arm or the force vector of the joint. When you increase both these distances, obviously the amount of force required would be less and it would be much more easier to perform the abduction. So the magnitude of torque generated now would depend on the dimensions and design of the prosthesis. So as Dr. Devesh told, it was started and conceptualized, and the first designs were the lateralized glenoids, but because they achieved the biomechanics well, but the lateralized glenoids had a few problems, and that's why they resulted in catastrophic failure, more because of significant shear on the glenoid component and early loosening of the component. So then Dr. Gramont came up with this design where the principle was to medialize the center of rotation, as we know, the distalize or lower the humerus to increase the force vector arm, and to have a constrained fulcrum. So this is the original Gramont design, and as I told earlier, it achieved all the principles of reverse shoulder, distalized and hence increased the F arm, medialized and hence increased the L2 arm, and thus it became very popular. Now, to understand better how it helps in increasing abduction, let me go through this principle. This is the center of rotation in a normal humerus, in a normal shoulder, where it is at the center of the humeral head. You can see here that only the part of deltoid fibers, the fascicle 2 and the fascicle 3, take part in the abduction process. If you medialize the center of rotation, as in the case of reverse shoulder, then more deltoid fibers would be taking part in the abduction process. More the deltoid fibers lateral to the center of rotation, more the deltoid fibers are incorporated in the process of abduction, and hence abduction biomechanically gets better. What are the effects of medialization on the function of rotator cuffs or the external rotator specifically? Because you have medialized the center of rotation, there is a slack which is developed on the tendons of the external rotators. This actually makes it more difficult, or there is a lag of the external rotation which is happening if you have medialized the center of rotation as it was occurring in the original Gramont design. The third thing which is important to know in the Gramont design was, because you have medialized the center of rotation, there is no or minimal deltoid wrap. What is deltoid wrap? Is basically when the deltoid comes around the humeral head on a normal shoulder, the central fibers of the deltoid wrap around the humeral head, giving it much more stability. When you medialize the center of rotation, that becomes flattened, and the wrapping of the shoulder or the wrapping of the deltoid over the shoulder is less, hence making the overall construct a little unstable. So these were the problems with the original Gramont design. First was the instability that I told you, the deltoid failure, and the third was scapular notching. What is scapular notching? Because of the medialized component of the humerus which was used, the medial edge of the humeral component struck on the inferior or the medial portion of the glenoid neck while in adduction, and this caused lysis of the bone in that area. So then the debate arose to shift the glenoid or the center of rotation to lateralized part. So Obviously, it had advantages of reduced scapular notching because the center of rotation was lateralized. Obviously, there was more deltoid wrap, giving it a much more stable construct, and it had a potential to improve the range of movement of the shoulder as well. So this is what I meant by deltoid wrapping. If you lateralize the glenoid, there is much more deltoid wrapping around the humerus. But there were issues with the lateralized glenoid also. As the earlier designs failed, these lateralized glenoids also tend to fail more because they had more stresses on the fixation, because it was, and the second was the momentum was increased. If you remember, we need to decrease the momentum to have a good abduction.
non-functional reasons. Third will be the primary osteoarthritis with the intact cuff. Now we have seen that the long-standing arthritic shoulders, there is definitely a rotator cuff is non-functioning. Even if the rotator cuff looks intact on MRI, the cuff is usually non-functioning because of the long-standing stiffness and arthritic situation. So when you do a total shoulder replacement in arthritic population, most of the time there will be a cuff deficiency and initial failure of the total shoulder replacement. So particularly in arthritic situations, having the B2 or C type of glenoid, there are very high chance of implant failure following the total shoulder replacement. So reverse shoulder replacement is indicated in advanced arthritic cases like this, and it gives very good results. Fourth indication is acute complex proximal humeral fractures. Now, whenever you have an elderly person with such a bad shattered fracture with a very less bone stock in the proximal humeral head, then whenever you cannot salvage by osteosynthesis, there are two options usually we have, hemi replacement and a reverse shoulder replacement. So the entire success of the hemi replacement is basically relies upon the tuberosity healing. And we have seen that the tuberosity healing is unpredictable following the hemiarthroplasty, following the fractures. So this is the case if you are operated for the hemiarthroplasty, and you can appreciate here that there is a deficiency of the greater tuberosity, and this is a failure. Even if whenever you want to use the hemiarthroplasty for the fracture cases, you have to use the platform system rather than the monoblock system, so that even if this type of complication happens, you have a platform based hemi, so you can just remove the head and you can convert this operation very easily to the reverse shoulder replacement. So this is again one tip I would like to share here. So this is the case we treated with the reverse shoulder replacement. You can see beautiful tuberosity reconstruction, and definitely when the tuberosity heals, patient will have a better external rotation and better function. But even if the tuberosity won't heal, these patients will do better following the reverse shoulder replacement. And this is the case 3-month post-operative follow-up showing good tuberosity healing. Fifth indication is revision of a failed hemi or failed total shoulder replacement. These are really challenging cases, and you need to have a good preoperative planning and all armamentarium with you. So this is again one indication. And again, final indication is oncologic lesions, tumors of the proximal humerus, where in wide resection, when you want to resect the rotator cuff, you can use the reverse shoulder replacement. In such cases, you have to use sometimes allograft composite processes to reconstruct the proximal humeral anatomy. So these are the indications of the reverse shoulder replacement. And regarding the approaches, the deltopectoral approach is very well described by Manoj sir. But there are classically two approaches described. One is the superior approach, also known as a Mackenzie or anterolateral approach, and the deltopectoral approach. We'll see one by one together. So we'll see the surgical approach. This is the saber cut incision, expose the deltoid. Deltoid is exposed and you find out the white raphe between the anterior 1/3 and posterior 2/3 of the deltoid. It is relatively an avascular zone. This is the white raphe, and you dissect it out with a scalpel or a cautery. Go to the acromion, and using a thin osteotome, sliver of the bone from the anterior acromion is detached to expose it. So whenever you want to reattach it, it has a good bony union and it will give good healing of this thing. And this is the case of fracture. So head is removed. Otherwise, when a cuff deficient shoulder, there is directly a head is seen there. When you cut the head, you have a very good, nice exposure of the glenoid in this case. There are advantages and disadvantages of all approaches. The advantage, direct exposure of the glenoid cavity. Very important, it preserves the subscapularis. It's very rare to have dislocation or instability following the reverse shoulder replacement when you want to use the superior approach. And it gives very good access to the posterior part of the glenoid, particularly in arthritic cases with the B2 type of glenoid. We have seen through the deltopectoral approach is very difficult to access the posterior part of the glenoid. But the real issue is success of the reverse shoulder arthroplasty depend upon the integrity of the deltoid, and here we are damaging the architecture of the deltoid muscle. So this is the real drawback of approach. Again, one important tip which Apurva has already mentioned, you have to put your base plate or glenosphere in the inferior 10-degree inferior tilt. So whenever you are using this superior approach, is sometimes difficult to achieve this inferior glenoid tilt, and it is not extensile. If you have some problem to the humerus or shaft, it is not extensile approach, no extension is permitted. So these are the drawbacks of superior approach of this procedure. Deltopectoral approach, again positioning, again very good, shown by Manoj sir, padded scapula, and we all know this approach in a great detail. It's very extensile approach. Again, left shoulder, conjoint tendon. It's important to release the subdeltoid bursa. CA ligament, whenever in tight situation, you do partial release. It is important to release the upper 1 to 1.5 centimeter of the pec major for better mobilization. And this is a CA ligament. I am showing it here. So ligate the three sisters, and then add in the subscapularis peel, and this is the humeral preparation, and this is the exposing the glenoid. So again, deltopectoral approach, we are very much familiar with that. It is through the internervous plane, extensile, unobstructed approach to the humerus. We get an excellent access to the inferior capsule and the glenoid, and gives less bleeding. Only issue, we have to cut the subscapularis, so instability is a big issue, and inconvenience in approaching the posterior structure, and at risk now is axillary nerve and musculocutaneous nerve. So subscapularis management, already told you, either do tenotomy, peel, or LT osteotomy. So in tenotomy, incising subscap from keeping a 1 centimeter or 1.5 centimeter of the lateral cuff, you incise the tendon, and after that you, after the surgery, you repair it very robustly using the non-absorbable sutures. Second is a peel, you erase from the lesser tuberosity with a scalpel or a cautery. And third thing will be lesser tuberosity osteotomy. Here, the theoretical advantage is there is a bone-to-bone healing once you repair it, but it compromises the proximal humeral bone stock. And whenever the proximal fit designs, we are using the humeral stem designs, this LT osteotomy will compromise the proximal bone stock, and better to avoid in osteoporotic patients particularly. So these are the subscap repair. Some people, they don't believe in subscap repair, but subscap repair demonstrated a reduction in the occurrence of the implant instability and medialized implant, particularly in medialized implant. So subscap management is a big headache, and even if you repair it, the healing rate is 30 to 40%. So French people have designed the deltopectoral subscapularis sparing approach. I have not used it, no experience of using this approach, but this is the deltopectoral approach. This is again coracoid process, conjoint tendon, subscapularis, and the humerus. You ligate the three sisters out here, and this is the safe triangle there. Here is the pec major tendon. So you release in this area, and you expose the inferior capsule directly. You remove the inferior osteophyte. You release the capsule directly like that. You lift up the subscapularis using Langenbeck, creating a layer of space between the anterior capsule and the inferior part of the subscapularis. Then again, you extend your release medially. Capsule has to be released. Again, put an Homan's retractor down and release the capsule from superior coracoid process anteriorly to all the way down, and you will have a nice exposure of the glenoids. So you can use this is again preparation of the humeral head, and this is again exposing the glenoids. So this thing I found it on the literature. This looks very promising. I have never used it, but this looks very good. So whatever approach you use, it gives similar short-term and long-term outcomes. So particularly you should use according to your training and convenience, and your familiarity is actually what is important. Thank you very much for your kind attention.
Thank you, Kalpesh Trivedi sir, for wonderful talk. Now I would like to invite Dr. Prathmesh Jain sir for his talk on relive demonstration on tornier perform stem.
So good morning everybody. In the sequence of the talks by Kalpesh sir, I will be just focusing on the exposure and how we do reverse shoulder arthroplasty in a small relive recorded video. So basically reverse shoulder replacement we can do by either deltopectoral approach or a deltoid split approach. The most commonly approach that we recommend is the deltopectoral approach. The important thing, as we all know, is a position. So you should be able to extend the elbow completely, so that we want to do all the maneuvers. So important thing is positioning. You need to extend the elbow whenever you are doing this procedure. This is the deltopectoral approach that we are doing in. We usually explore the cephalic vein, and then we are exploring the deltopectoral interval. So we go between the deltoid and the pectoralis. We are releasing the fascia. You can see, and you need to be on the lateral side. So my preferred approach is to be on the lateral side of the cephalic vein, and that will give me a better exposure of the glenoid. So this is how we expose it initially, and then I will do a finger dissection to do a exposure on the clavipectoral fascia. So here we are exposing the the cephalic vein, and then just so this is the deltopectoral interval that we are clearing up. So once we have cleared the deltopectoral interval, we clear the the clavipectoral fascia, and in this area we will be able to identify the important structures. So right now we are putting one Homan on down and one Homan on the top, and this will lead to a good exposure of the area. So here what you can appreciate is we are releasing the lower part of the pectoralis. So approximately, as Kalpesh sir also told, we release approximately 1 centimeter of the pectoralis, and then we will be exposing the subscapularis muscle. Now, as discussed, you can expose the subscapularis by 3 ways. You can do a tenotomy, the LT tenotomy, you can do a subscapularis tenotomy, or you can do a peel approach. So the approach that I usually prefer is the subscapularis peel approach. For that, the first structure that you want to identify is the biceps tendon. So this is the long head of the biceps that we have identified, and we are exposing the long head of the biceps on the medial aspect. So you identify the long head of the biceps, go on the medial aspect, and on the medial side of the long head of the biceps, you will be identifying the subscapularis muscle. And I would usually take 1 or 2 sutures, maybe fiber wire sutures on the medial aspect of the subscapularis, and this will also help me to tie the subscapularis tendon in the end. So this is how I will identify and grip my subscapularis, and after that I will do a peel approach, which will start from the rotator interval and which will go down. And in this approach you will take the subscapularis along with the capsule together. So as we are exposing the subscapularis initially, the upper part of it is subscapularis, and the lower part of it will be the capsule. And once we are harvesting it, we are clearing it down. The thing which is important is to release the capsule from the inferior aspect. You might have osteophyte formation on the inferior aspect, so you just clear the capsule from the inferior aspect. You need to be very close to the bone because the axillary nerve is very close, so you need to do the dissection subperiostally, and you need to be very, very close to the bone to do this kind of dissection. You can go down, release pectoralis minor a little bit, and then you can put one homens on the inferior aspect, and then we need to release a little part of the capsule on the top and the little part of the capsule on the bottom. As emphasized in the last talk, you might need to release some of the adhesions pertaining to the subscapularis tendon. So once you have exposed the humeral head, you need to go down and ask your assistant to give a little bit of external rotation. So as similar in the hip joint, we are doing a little bit of external rotation and the hip dislocates. Same, we are doing a little bit of external rotation here, and then the humeral head will dislocate, and this will slowly, with a little bit of external rotation, we will be able to dislocate the humeral head, and then we can adjust our homens into the place so that we can put our humeral cuts. Now, as far as the humeral cut is concerned, there are multiple ways to do the humeral cut. You can make the humeral cut directly by using a freehand technique, or you can use this nice jig from Stryker. The jig is intramedullary, so there is two kinds of jig which is available: an intramedullary jig and an extramedullary jig. You put it into the medulla, and then you put the zig. The zig will cut the humeral head at 135 degrees of angle, and then this jig can be mobilized 2 millimeters up and down with the use of this jig. So you can actually check and ascertain what level of cut you have to maintain. The important thing here is the version. So you need to cut it in the version where it is, because this is an inlay system. The version of cut is very important, and you need to be very accurate of your version when you are cutting the cut, because the processes, and you need to see the cut here. The cut is optimum, and when you are doing a planning, you can actually see how much of cut you want to make, and so blueprint will be discussed shortly. And in the blueprint planning, you can actually plan the amount of cut and the amount of resection that you want to make. So once you are done with your humeral cut, there is a very nice protector which is available in this system. So this depends on the size of the humeral stem. So there are 1, 2, 3 and 4 sizes which are available. In Indian patients, usually for females, we use number 2 stem, and for males it will be number 3. So if whatever the size of the stem you can ascertain, you put the protector right there, and then you can important thing here is the removal of osteophyte, because we don't want these osteophytes to come in between when you are doing the exposure. So you can remove the osteophytes which are there, and then on the freshened edge of the humeral cut, you will just apply your protector and let the whole humeral head cut go posteriorly with the glenoid retractor. So the application of protector is important, because this will prevent the damage of the humeral metaphysis with your retractors, because when you are doing the posterior retractor, this may damage the humeral shaft. So just you put the so this is a size 3 protector. You put it onto its place. Occasionally you might have to adjust it and put it on the right place. So this is my exposure of the humeral cut. We might have to revise cut sometime, because occasionally it might not be fitting appropriately. That is it. So in this particular case, we just revise the cut a little bit, and then we just put the protector on its place, and then push the humeral head posteriorly, and then we have changed our camera, and now we are seeing the end-on view of the glenoid. So here we are preparing the glenoid, and we are exposing the glenoid. So glenoid exposure, there are some important tips and tricks. You need to identify the biceps tendon, and when you cut the biceps tendon, you cut it on the posterior aspect, so you can take out the whole of the posterior labrum along with that. So here we are exposing the posterior labrum along with that, And after that, we need to remove the anterior labrum, and then we need to clear the tissue around the subscapularis. So you remove the capsule on the anterior part of the subscapularis, and then we can remove the tissue on the inferior aspect of the glenoid. So once you remove the tissue on the inferior aspect of the glenoid, there are two structures, the long head of the triceps. So if the tissue is very, very tight, you can actually release the long head of the triceps as well. So on the most inferior part, you will get the long head of the triceps. Here the important part, as I told you, on the humeral side, again you have to stay very close to the bone. You don't have to stray away from the bone because your nerves will be lying right there. So you need to give a good exposure. Now with respect to the capsule, there are different schools of thoughts. Dr. Vahid, who just presented, he usually does a whole of the capsulectomy. So you can do a capsulotomy as I do, or he'll just expose the capsule and he'll remove the capsule anteriorly completely. So he does a whole anterior capsulectomy for a good exposure, and his exposure is like a textbook. He removes whole of the capsule in an en bloc fashion, and then the exposure of the glenoid is excellent. So here what we can see is the capsule, is the glenoid, which is seen end on, and you can see a very nice view of the glenoid. There was a loose body which we removed. The loose body is usually seen in the subcoracoid recess. So once we are done with that, we have got two options here. You can use a 0 degree, or you can use a 10 degree, depending on your planning. So here we are using basically a drill guide, which will guide us on the anterior, on the central guide pin. Now the central guide pin should be on the center, and this is a trick that I learned from Dr. Vahid, that you have to pass the wire in a way that is exits the anterior part of the glenoid neck. It should not go posterior, it should go anterior, and if you put your finger anteriorly on the glenoid neck, you should be able to palpate the tip of the wire on the tip of your finger. So that is a good trick. And then there you have to ream the face of the glenoid with this special reamer. This is a half cut reamer, so it is easy to pass. This is better as compared to the other competitors because it goes very easily onto the glenoid neck. So you prepare the glenoid face with these reamers. So two size base plates are available, 25 and 29. In Indian patients, most of the times, 80% of time it will be number 25 will be used. But in gigantic males, you can use number 29 base plates some occasionally. And then you ream the central reamer, which is 11 millimeters. So you ream the central reamer and then you took it off. For the central fixation, Stryker has got four options. You can use a 6.5 mm screw, you can use a 9.5 mm screw, you can use a small post, and you can use a large post. And so a good things of all kinds of revision scenarios can also be addressed. So the most common screw that we use is a 6.5 mm screw. You put the central guide pin for the screw, and this guide pin is marked. So you put the guide pin in, and then you ream for the central screw, and you can see the measurement on the drill bit itself. And if you are in doubt, you take the higher one, because we want to have the bicortical purchase of the central screw. So if you are between 25 and 30, prefer to use a 30 as compared to 25. And then the base plate assembly, this will usually be done by the company person, but what you need to do is to counterclockwise fit the screw into the base plate. So it will be a screw base plate assembly, and this once fit will be the screw will be loose on the base plate, and once it is assembled, you put it onto the glenoid face. The important thing here is you need to have the correct orientation. There will be a mark on the superior aspect. So you put the mark on the superior aspect, and then you start putting putting the screw inside. In the last screw threads, the screw will lock with the glenoid base plate, and this will be a locking construct which you will get. So here the base plate is inserted, and you can you visualize that you have two multi-axial locking screws and two compression screws. So two compression screws anterior and posterior, and two multi-axial locking screws which are superior and inferior. The superior and inferior screws are more important, and you need to put them into the maximum possible length. As compared to the other competitors, this system has an advantage because this is a multi-axial locking screw which is available. So you can place it, you can guide it anteriorly or posteriorly, and you can get a more longer screw as compared to the other design. So you have a multi-axial locking screw on the superior and inferior, and this will give you a more better chance of getting a longer length of the screw and better fixation on the superior and inferior. The anterior and posterior screws are optional, you might place it. Now recommendation is, if you are doing a lateralization of your glenosphere, either by using a lateralized base plate or a lateralized glenosphere, you need to use more number of screws, because the amount of lateralization you increase, you are putting more stress on the glenoid and base plate interface. So if you are doing lateralization, try to put more screws, because the construct has got more chances of losing. If you are not lateralizing, 2 screws are enough. If you are lateralizing, you might need to increase the number of screws to 3 or 4. Now there is a collar reamer which is important, because you need to ream it, but I use it with the hand. And then you need to put your glenosphere onto the base plate. Now this is a tricky step, and occasionally it might be worthwhile to remove your posterior detractor to do this step, because this step can occasionally be difficult, and then once it is impacted into the humeral, into the base plate, so this step occasionally can be challenging, and as I told you, occasionally it can be helped by using a screwdriver to put the screw on its place. So once you put the screw into a screw onto its place, you tighten it, then the final impactor is important, which impacts the glenosphere into the base plate. As far as the humeral preparation is concerned, this is an inlay system. So you need to protect the metaphysis, you need to size it well, and then you put it in the center of your metaphysis. So once you put it on the center of the metaphysis, you drill the center guide pin, and then you have a metaphyseal reamer. You can use it on power, or you can use it on hand. So in Indian osteoporotic females, typically ladies, if you are using it on hand, this may cause fractures sometimes. So it is recommended that you do reaming with your hand only. Don't use a power reamer. So just use the reamer with your hand and ream it slowly, so that you don't encounter any fracture. This is especially important for females. For males, it should be okay. So this is how you prepare it, and this is the metaphyseal preparation. And this is the inlay system, so it will go into the metaphyseal stem. So inclination should be good and version should be good, and that's why the cut of the femur is important. And then you can use your stem entry. Now stem options are many. So in this particular striker system, you have a standard stem, a plus stem, a long stem, and an extra long stem. So for every size, like for number 2 and number 3, you will have number 2 plus, number 2 long, and number 2 extra long. So normally if you have a standard case, you can use 2 plus, or if you have some doubt in your fixation, you can use a longer stem. So in this particular case, we are using a L stem, or you can use a plus size stem, whatever you want. And then you have to impact. So when you are impacting, you have to impact it in 2 directions. You have to impact on the distal direction and sideways. So this is how you impact it. So impaction is twice. So you will hit one hammer on mallet on this side and one mallet on the other side. And this way you can have a very good fixation of the humeral stem on the metaphysis. If you want to repair the subscap, you can pass your pins, your wires, and you can pass the sutures for the repair of subscapularis later. In this particular system, the inlay system, the repair of the subscapularis is much easy as compared to an onlay system, because the construct is loose, and hence a very nice anatomical repair is possible in the end of the subscapularis as compared to an onlay design. Because in onlay design, that is more of lateralization, and subscapularis repair can sometimes can be tough and difficult. So once you have put the stem into your place, then you have multiple options in your insert as well. So there are 2 kinds of insert which are available. One is a symmetrical insert, one is an asymmetrical insert. The symmetrical insert is basically same on the top and bottom, and this will make your construct a 135 degree angle, whereas the asymmetrical insert will make your construct from 135 degrees to 145 degrees. So depending on your stability, if you want extra stability, you can use an asymmetrical insert, because asymmetrical insert will give you more stability, and specifically chances of dislocation will be reduced by using an asymmetrical insert. So here we are just passing the sutures, and then after reduction we will be tying the subscapularis into its place, and if needed we can tie subscapularis to the supraspinatus, that is called as a rotator interval closure. So by and large this kind of a very loose closure is important. So here we can see that the biceps can be closed very easily, very comfortably in a low tension way here, because we have used an inlay stem and then lateralization on the glenoid. So this construct is a very stable construct, and this will give you a very good range of motion as compared to an only kind of a design. Thank you.
Thank you, Prathmesh sir, for the wonderful demonstration. So
all the speakers.
yeah. So I would like to call all the speakers on the dais.
Meanwhile, we can take question answer if there are any.
I have two questions for Dr. Apurva. Sir, you described that you put glenoid base plate a little inferior, eccentric. Does it affect anatomy of axillary nerve? And there are almost 100 surgeons. You told 4 combination, lateralized base plate, inferior humerus. Which one of 4 are you using? As far as prosthesis is concerned. 2 questions.
So, to answer your first question, the inferior eccentricity of the glenoid glenosphere that I was talking about is not to the tune of 1 to 2 centimeters. It is just to the tune of around 3.5 to 5.5 millimeter, as discussed earlier also. So that doesn't affect your axillary nerve because it is almost 1.2 centimeter below your medial margin of scapula. Plus you are dissecting the inferior capsule out of the way. So you are under vision putting it, and it doesn't put your axillary nerve in harm's way. So that is for the first part of your question. The second part is, as far as I am concerned, a medialized glenoid and the lateralized humerus is the way to go. But if there is a defect on the glenoid side, as for example in a reverse hip, then probably a bioarcia or a lateralized glenoid and an inlay humerus would be a good balance between the system. But primarily, my go-to is a medialized glenoid and a lateralized humerus.
You plan it pre-operatively only, that
Yes.
which you will go.
Yes.
No power of decisions.
No.
Thank you.
My question is to the Dr. Devesh sir. What kind of design do you prefer, inlay or onlay? It's patient specific or?
So for female patients and small shoulders, I prefer inlay, and for the bigger shoulders, I prefer onlay. And one point that I want to highlight is, even if you take a lateralized glenoid, if you think about lateralized glenoid, then also it is a medialized glenoid itself. Okay, so when comparing to native shoulder, when you shift your center of rotation from the humeral head to the glenoid, when you talk about lateralized glenoid, is just more than 5 millimeter lateralization to the face of the glenoid. Okay, so it is also very well medialized glenoid. So don't think about like lateralized glenoid, it will increase instability and all. So basically lateralized glenoid is a term only, it is also a medialized glenoid itself. Okay. Yeah, medialized central of rotation, yes.
Yeah. When you drop down the scapular, I mean deltoid origin, superior record, don't you think chances of later on scapular fracture will be much higher?
So I have never used.
I am asking Kalpesh.
So there are advantages and disadvantages of both the approaches. So definitely we are violating the deltoid muscles. So it has to be avoided in osteoporotic patients, as I already mentioned. There are definitely chance of post-operative deltoid-related complication in there.
I have.
Most commonly used approach is delta pectoral. So I think the message that should go is the use of delta pectoral in most of the
Yeah.
It's like
almost can anyone in this hall, those who are doing good reverse shoulder, anyone regularly using superior approach?
No,
That was I was telling.
Yeah.
Most of our cases are, we are happy with deltopectoral.
So when we started in initial cases, we used the superior approach in earlier cases. But right now, I think everyone is using deltopectoral approach. It's more extensive.
My question for Prathmesh.
Yeah.
Prathmesh sir,
Sumant uses a lot of superior.
you use always inlay technique, inlay in humerus, and you always lateralize the glenoid.
So if I'm using the striker system,
Okay. Inlay for humerus and always lateralize the glenoid.
inlay humerus, the performed stem, and lateralization of the glenosphere, I lateralize on the glenoid either from the base plate or from the glenosphere, and that is usually to the tune of 3 millimeters.
And you incline or put the base plate inferior any?
So that is a very good thing, and that is something which we discussed. So initially it was a lot of focus on inferiorizing the glenoid, the glenosphere. Now a lot of inferiorization will lead to a lot of combined distalization, because from the humeral side you are also distalizing, and from the glenoid side you are also distalizing. The use of inferiorization origin because there was a lot of scapular notching with the earlier designs. So for the Gremot style of prosthesis, there was a lot of scapular notching which was there. With the recent design of prosthesis like this one, the Perform and the Striker system and the other Zimmer Biomechanics system, there is a chance of scapular notching has become very, very less. So nowadays, lot of inferior offset is technically not required. So you can use a standard offset or maybe a 1 degree of inferior offset. A lot of inferior offset is not required. Dr. John Spelling, who is a designer surgeon of Zimmer Biomet, he recommends occasionally reversing. So he uses the offset on the other direction. So he used to cover the glenoid face with reversing the offset. So he uses a superior offset instead of inferior offset to decrease the distalization. So inferiorization, yes, you can do in some cases, but it is not mandatory to be used.
Whenever you do excessive distalization, there is lot of stress on the acromion, and there are chances of stress fracture of acromion. So in preoperative planning, you should not aim for too much of distalization. I think 25 to 30 mm of distalization. Manit, what is your saying on that?
So I agree completely what you're saying, and I would add something is कि हमारे पास आता कौन है? What's the typical patient that comes to us? It's a 60-year-old female, right? That's a typical sort of patient cohort that comes to us. सबसे बड़ा problem inlay prosthesis का ये वाले patients में है, they have poor metaphyseal bone stock to begin with. The minute you run the reamer, all you're left with is just a papri. Now, how much integration of the bone is going to happen at the metaphysis in these patients is something that you need to be cognizant of as well, right? Because I used to do inlays before, now I completely am onlay only. So, and I prefer the onlay system because I get to medialize my glenoid. That vertical cut shifts me, the onlay shifts me lateral on the humerus. But in these osteoporotic females that are coming to us, अगर हम उनमें ही इतना सारा metaphysis हटा रहे हैं, so what are we gaining? We're not gaining anything from those inlay designs for them. In fact, I would go completely against what you say, is that I would use the inlay design in the big patients, the big humerus, because I'll get a good metaphyseal bone stock in them. In these elderly females, the minute you run your reamer, there's nothing. So if you have just a papri, what integration is going to happen?
So what about stuffing of the joint?
Yes, but what about failure of the prosthesis? So for a prosthesis to work, and all the inlay prostheses are all designed for metaphyseal fit, right? So if you have no metaphysis, where does your healing happen? An implant can't heal to a cortex. It can only heal to a metaphysis.
So where does only implant fixes?
Only to above, na? So your...
So that is the problem. The osteolysis will occur with the proximal humerus.
Would you rather have that, or would you rather have a loose metaphysis? So the only way that only, so in my practice what I do, and this is, I would say it's a little bit different, is that I do only for everyone. And I haven't had, like, I've gone through that whole complication ka journey. We do about, on average, I would say about 20-25 requests per month. So वो सारा जर्नी में मैंने स्टार्ट से सारे कॉम्प्लिकेशंस देखे हैं, मतलब every single complication I've gone through it. For your approach, I am completely agree. I use deltopectoral, right? And the funda behind that is कि अगर आप deltoid को split कर रहे हो, right? Remember आपका सारा reverse ही deltoid पे टिका हुआ है. आपने deltoid को touch किया, deltoid को split किया. Why do we want to compromise? The thing that needs the deltoid to work for its actual performance, why do we want to compromise the deltoid to begin with? So that is why I also started with superior, and then I quickly shifted to deltopectoral.
So can I add on to this? So whoever are doing this RSS, if you see the measure the glenoid, most even 25 mm sometimes that base plate is bigger for our patients. And as Dr. Manit rightly said, that putting an inlay, where sometimes you need to cut a little extra to get that space with the smaller joints and tight joints. When you do that, there's nothing left for inlay to fit in. This is where the only system, and all systems, if you see, there's a very big study, multi-center study by Dr. Ashish Gupta. He has compared all the systems, and every system has a good and bad points. So you just learn one system, stick to it, and then gradually shift to other. This is more of a theoretical discussion rather than a practical one.
Yes, and it's just like TCAR, sir. मतलब जिससे आपका you're not changing your TCAR processes every day, are you? So why do we want to do that for reverse? The system that you've learned and you're good at, your hands are good with, right? Use that system, and you can play around with the measurements of that system. The other thing I would add is कि what you say correctly about the size, it's so important. So जब COVID आया था, we did this study, and so सबके CT chest हो रहे थे, तो साथ साथ हमारे को दिमाग की बत्ती चली. So we thought कि why not look at their glenoids also. So we did the world's biggest study of 520 shoulders, looking at the CT scans of the shoulder, the glenoid dimensions in the Indian population. The average glenoid maximum AP dimension we found was 25.7 plus minus 1.3. Which means that 80% of the people that we were actually seeing in the study, they were oversized on a 25. That means हम natural born overhangers हैं, and based on that, then subsequently we've developed a classification system for it as well. But the base plates that we have currently, the 25, it's too big for us. And you would have also, all of you would have seen कि जब हम वो females करते हैं, इन्नू सा उसका glenoid होता है. Right, and you end up seeing that there is some overhang that happens, but then we accept it because we do not have the option of downsizing on the base plate. Yes.
Yeah.
Yes.
And most of the stems, what we are using, it is having proximal fit. So whenever you are fixing the stem, you have, it is advisable to use the bone graft from the head, and you take out the cancellous chips or bone graft from the head, you impact it, and then you try to fix your, just like a hip joint. So it's impaction bone graft. It helps in a proximal fit of this type of stem.
Sir, is onlay or inlay is pre-op decision, or is it an intra-op decision? And can we change it intra-operatively, or do we need to order it separately, or
They are different systems. They are different philosophies. So you have to plan it, but you can have some aspects of onlay into your inlay design, or some aspects of inlay into your onlay design. So it's basically a system. It's basically a philosophy. So you need to order one system. So striker, if you see, is the inlay based system, and if you have to use striker, you have to use the philosophy as per the inlay philosophy. So if you have to shift this to a onlay, you might make it a little bit the stem a little bit proud to make it a onlay.
The same system.
Same.
So it is entirely pre-op decision.
Yeah, you have to order. Yeah, you have to order the implant. So if you are using the striker, it's basically an English system. Planning is very important. So we will be coming on to the planning software. So striker comes with the blueprint planning software, and for all the beginners, I will strongly recommend that you do the planning. They will give you the planning, and they will give you their work, but you can adjust the planning as per your needs also. So you can go on the computer and you can shift, and you can adjust the planning as per your needs also. So for beginners, it is always very useful to use a blueprint software, and that there you can plan each and everything, what size of implant you will get, what size of split you will get, what size of stem you will get, what size of the central screw size you will get. So you will get everything where you have to place, and if there is a wear, so if there is a glenoid wear, they can even guide you that you can use an augment. So for initial part of practice, it is always good to use the blueprint. It will just take another 2 or 3 days for the planning, but it is always useful. So basically, you would give it for a CT scan, and then that CT raw images has to be gone to the blueprint, and that will give you a lot of planning and make your execution much easier.
Sir, how do we repair subscape with inlay design?
So the biggest advantage is the subscap repair is easy. So as you saw in this, because inlay is a loose design, and it is you don't lateralize your humerus. So the subscapularis repair is not tight; it is loose repair. So you can repair. You put 2 sutures, 2 fiber wires into your LT, and then you have fast sutures to the subscapula. You just repair it. It's a simple transosseous repair. Yes. Simple.
If that is safe for injury only.
Yes.
So do you have fins in onlay design in the stem?
No, fins are there for the fracture stem. For the regular stem, you don't get it. So fins are there in the fracture pattern of stems which are available. So you don't need it for a regular reverse for an osteoarthritis.
You can also use fingers for that, because you don't need to impose fingers and then pass sutures to
So you mentioned that you tend to put that glenoid guide wire tend to angle anteriorly.
So if you want to error, it should be central and it should go into the glenoid bolt. But if you want to error on the anterior side as compared to posterior. Because if you put it anterior, you will get a more bone bolt. So ideally, you put your finger on the anterior glenoid neck, you insert it completely in, and you should ideally feel the tip of the your guide wire on your fingertip, and then if it is there, you are on the right position.
Is it to recreate the retroversion?
No, it's not. It's the central point. The central point is little more anterior as compared to.
So if you see the scapula, you just see the pictures before the scapula.
We'll show it on the blueprint.
If you see the blueprint, then these are shaped like this. Then the scapula becomes very nice. So then the best part, you get the best purchase of the screw.
Thank you.
So whenever I can, I would repair. Whenever I would do it. So that is the important message. So subscapular is a very important protector against dislocation. So there are 3 things. It will make your construct safe, stable, and it has got lesser chances because you have a soft tissue coverage. The chances of infection is also less. You get a more benefit as far as the stability is concerned. So the stability of the construct will increase. So you will get a better coverage, and your internal administration strength will also. So whenever possible, I would repair.
And जैसे आपने दिखाया था ना, at the end, you should not be able to see your prosthesis. So at the end of the surgery, it should be such a good closure that you cannot visualize your prosthesis. That's when you know you've done a good job, right? And what we use a reverse Xbox for the repair. आपको नहीं पता होगा सर, Xbox. So there's a reverse Xbox configuration. So it's a PlayStation type game, but for that we use in the repair. तो हम क्या करते हैं? Before when I started doing reverse, I was not very much into doing subscap repairs, and luckily I didn't have so much anterior dislocation as well. But then over a period of time I have become all about subscap repair. So now we ensure that it's a robust repair. We use tapes, and जो पतली tapes आती हैं striker की 1.2 की. So what I'll do is, before passing my stem, I make 2-3 drill holes into the metaphysis at the LT, run a free needle with these tapes through it, and then using the tag sutures that I've made initially, I will bring it on top of the LT and have the arm in about 20 to 30 degrees of external rotation. Then I use the free needle to take the bites of the tapes and fix it in a reverse Xbox configuration so that you get a very good subscap repair. The negative corollary to this, I had one patient who was operated by a friend of mine. We were in medical school together. He practices in Australia. So एक patient थी, she is based in Delhi, but she had gone to Australia. she'd had her reverse done by him. So then he called me and he's like, कि यार इसका ना movement नहीं आ रहा. It's been about 6 months down the line, and she came to me, painful shoulder, 20 degrees movement, did the X-ray, did the CT, everything looks perfect, right? And we couldn't figure out कि क्या हो रहा है इसको, why can't she get the movement back? No nerve injury, no loosening, no nothing, right? So then I told her कि we'll just go inside and we'll explore and we'll see, और कुछ ना कुछ हमें मिलेगा वो हम कर देंगे. So we opened up her up. The only thing that was limiting her movement, the subscap had been repaired so tightly, it was actually preventing her movement. So all I did was I just cut the subscap and her full ROM came back. And she is also the relative of one of the doctors in our hospital, so she's been very happy since then. So you cannot do over tight subscap repair as well, because what it does is it ends up limiting your ROM and causing pain. So it needs not be loose, not be tight. It's that Goldilocks principle.
When you cement your stem, when you use cemented stem, and do you have any chances at the time of surgery you change your mind?
So two definite indications of using cement is, one is a tumor, which Dr. Abhishek will cover, and second is a trauma case in which you have a fractures, 4-part fracture dislocations. That is second case. And third case, if the third scenario, if you are not getting a good fit of your stem, so in that case, you don't get a good metaphysical fit of your stem. So in that case, you can consider it. So trauma, tumors is definite indication, and loose metaphysical fit is a related indication.
Same stem
You can cement. So in this perform stem, it is a cementable stem. So you can stem the lower part of the cement the lower part of the stem. So it is a proximal coated stem. So approximately about 3 centimeter is coated, and below that it's a regular stem. So you can cement the lower part, no problem.
Sir, intraoperatively, do you check the version and inclination of the glenoid component, or is it dependent on the central screw fixation only?
Yes. So that's why the planning come into place. So you have to get your first central guide pin correct. So if you are placing the first central guide pin correctly, you will be putting a good inclination and good version. So that is why you have that option. So the things that you can do to improve that, one is a blueprint software. The second is the 3D printing. So there is a company called as Jachal from Vadodara. So they are doing very good work on the 3D printed guides. So you can put those guides, and that guide will give you a central guide pin directly. So that is a very good, one very good technique. And then they have the regular 0 degree and 90 degree guide, which will give you a guide of putting the central guide. So these are the options.
After putting the guide pin, actually, always I check under IITV, double confirm before starting the running. That's again I can use it.
Sir, as I see in the video, you have impacted the glenoid with the base plate.
Yes.
And to the first screw.
No, so in this particular system, so there are two kinds of system. One is a system where you impact the glenosphere onto the base plate without a screw. So in those kind of systems, you just impact it and there is a Morse paper and that will lock. So in the second kind of systems, you have a screw attachment of the glenosphere to the base plate. So in this system, you have to impact it and then you screw it. Once you screw, the screw will impact with the Morse paper, and then you have to do the final 2 taps to impact the final part of the glenosphere into the base plate. So screwing is important. So screw will lock it. You will hear the noise of the screw locking into that, and finally you have to tap it twice to impact the base, the glenosphere into the base plate.
So this is not non-Morse taper. This is Morse taper design only.
In this system,
yeah.
So in this system, you have to do screwing and then tapping in the end.
But the final tapping mechanism, the basic design on which it works is a Morse taper, not a flat on flat.
Yes. Thank you. So we can start with the next session.
So with this we end the session. Thank you, moderators. I would like to invite the moderator for the next session. Okay, so can we have a photograph for all the moderators and the faculty of this session, please? I would request Mani Tarora sir to felicitate Dr. Devesh Shah. Thank you, sir. I would request Prathmesh sir to felicitate Manoj Mehta sir. I would request Nandan Rao sir to felicitate Apurva Dodia. I would request Nishit Sangvi sir to felicitate Kalpesh Trivedi sir. I would request Abhijit Salunke sir, who is the Secretary of Gujarat Orthopedic Association, to felicitate Prathmesh Jain sir. So with this, we end our first session. Now I would like to call upon the moderator for the next session, Dr. Kalpesh Trivedi sir, Dr. Manoj Mehta sir, and Dr. Devesh Shah. And the first talk is by me only. So thank you, chairpersons, and the previous session has made my life very easy, and as we all know, subscapularis muscle is very important as far as reverse shoulder arthroplasty is concerned. So since morning we have delved into a lot of biomechanics, but now let us understand how important is the subscapularis muscle. So the outline of my talk, I would like to introduce the biomechanics of reverse shoulder from subscapularis perspective, then how subscapularis repair is important with respect to the different parameters of reverse shoulder arthroplasty, then what is the new things that has come up as far as reverse shoulder arthroplasty and subscapularis is concerned, and then the practical decision making, because the previous session discussion was going on. Many of you might be confused that what to do and what not to do with the subscapularis. So let us start. Now, as we all know, that subscapularis is the essential muscle that we have on the anterior aspect of the shoulder joint. It gives the anterior force, it is the anterior force couple of our shoulder joint. But when we are addressing the subscapularis, we have to balance between the stability and the motion. As Manit Arora sir discussed one of the case that that lady was unable to lift her arm or get good range of motion. So we need to balance between the stability and the range of motion. Now let us understand the biomechanics. So as far as reverse shoulder is concerned, the most of the stability it comes from the implant design and the deltoid. But subscapularis is the secondary stabilizer and it protects the anterior dislocation. But whenever, so we already discussed the biomechanics, medialized design, lateralized design. So in medialized design, the subscapularis has lot of role. In lateralized design, still we can just give away with by not repairing the subscap. So how does the center of rotation change and how does the function of subscapularis changes with respect to it? So when the center of rotation okay, so when the center of rotation in the native joint, as you can see, few fibers are above the center of rotation and few fibers of subscap is below the center of rotation. So this portion can act as the abductor rather than adductor. But when we are doing a reverse shoulder, as you can see, all the fiber goes below the center of rotation. So that means it acts as an adductor. So there is a role, some role reversal as far as subscapularis is concerned in post arthroplasty biomechanics. Now, what are the ways we can address the subscapularis? It is already discussed. There are three ways by which we can address the subscapularis. One is the tenotomy. In classical deltopectoral approach, just cut the tendinous portion of the subscapularis and while doing the final closure, just do the end-to-end repair. The second one is subscapularis peel technique, which is my favorite technique, and in that locate the bicep tendon, intertubercular sulcus, cut the bicep and then take the stay suture and start peeling off subscapularis slowly and then do your release. And once you have completed the implantation, just take the bite in the pass the needle through the bone and repair your subscapularis as much as possible. And the third technique is the laser tuberosity osteotomy. This gives the strongest bone to bone healing, but it is technically demanding. So I would recommend, if you are doing it for the first time, go for subscapularis peel rather than laser tuberosity osteotomy. So this is the small video which allows us to, which gives a good idea about how to do laser tuberosity osteotomy. How to play? Can you play it for me? Yeah. So arm is in the external rotation, little bit of abduction. Delineate the laser tuberosity osteotomy. The superior margin, inferior margin and the intertubercular sulcus should be well identified, and then with the curved osteotome, start taking off, start hammering slowly, check that you do not do the periprosthetic fracture or the iatrogenic fracture, and once that osteotomy is complete, start take the stay suture and start releasing slowly. Once that is done, the repair method remains the same. So this is how we repair. Use fiber wire rather than ethibond, because as we all know, ethibonds are more prone for infection. Avoid over tightening. Now, with respect to the head humeral neck shaft angle, how does the role of subscapularis is there? So repairing the subscap increases the stability on the anterior aspect of the shoulder joint, number one. Then higher the head humeral neck shaft angle, lesser is the requirement of the subscapularis angle. So with 155 degree you can just give away without repairing the subscapularis, but in the 135 degree, which is from the striker we should aim for repairing subscapularis always. Then the glenosphere size. So the larger the size of the glenosphere, better is the stability, and you can give away without repairing it. But when you are using a small glenosphere, you should always tend to repair the subscap. So whenever we are repairing the subscap, what we are doing is we are closing the anterior space. So lot of dead space is getting negated. So the post-op hematoma or the chances of infection is very, very less. So the role of subscapularis is also has a role in periprosthetic joint infection. And the clinical outcome, as we all know, if we are repairing the subscap, it gives us better internal rotation, better power, but it might be at the cost of weakening our external rotation. And the effect on subscap dislocation, so that is already discussed. Now what is the food for thought? So Kalpesh Trivedi sir has already discussed that there is a superior approach and there is a deltopectoral approach. But if we do not want to touch the subscap, then what are the options that we have? So there is something called as a AMS, anterior muscle sparing approach. Still it is new concept, it is evolving, but when the thought for that anterior muscle sparing approach came, there was a poor visualization of the inferior aspect of the glenoid. But then some other surgeon, he came into the picture and he told us that we can make some small window in the like this. So as you can see, okay. So this is the small window below the subscap. With this we can take out the inferior osteophyte, inferior fibrotic material, inferior soft tissue, everything, and then we can finish our procedure from the superior window. Now what is the debate all about? So there is a debate which is going on since time that whether we should go for repair or we should not go for repair. So what are the points that are in favor of repair? So it adds the anterior stability, it improves the internal rotation strength, and it also prevents the dislocation. What are the points that are against the repair? So whenever we are using the lateralized design, we can avoid subscap repair. It avoids the external rotation and it simplifies our surgery because we don't have to repair anything. Now one study showed that when the subscap is not repaired, our internal, so as we all know, internal rotation is one of the most neglected range of motion in our shoulder joint. So when the subscap is not repaired, it is compensated by the latissimus dorsi, teres major and pec major. So now I am confused. So what are the practical decision making at the end of the day? We want to learn that, right? So whenever there is a young active patient with good tendon, then always go for repair. When the person is elderly, low demand, you can avoid repairing it. In revision reverse shoulder, most of the time there is a fibrotic material, so we don't get anything to repair. So in that case, we have to rely mainly on the implant design. So the take home message is the subscapularis play secondary role in reverse shoulder replacement. The repair is more important in the medialized designs. Lateralized design, the repair is optional. Always aim for balance between mobility and stability, and individualized according to your patient, like it is what implant you are using, onlay or inlay, how is the tendon quality, and what is the patient's demand. With this, I would like to invite to our next meeting, AAC 3.0 on 18-19th April 2026. And also I would like to request all of you that we are bidding after 25 years for IOACon 2026. So if you are IOA member, please do vote for it. Thank you so much.
Shall I call upon the next speaker?
Thank you.
Thank you, Dr. T. Now, the next talk is rotator cuff tear arthropathy by Dr. Kaushal Patel.
Good morning to all. Thank you, Dr. Prathmesh sir, Tirth sir, and Striker for the invitation. So we'll start with the very debatable topic, whether to consider reverse shoulder arthroplasty for the massive irreparable cuff tear without arthritis. So it's like a uni versus HTO in the knee. So it's like a whether to consider it or not. So we'll try to find out the answer of this question at the end of debate. So what are the indications for the reverse shoulder arthroplasty? We all know that cuff tear arthroplasty is the most common and first indication for the reverse shoulder. The another one is a irreparable massive cuff tear. Another is a fracture, the failed rotator cuff repair or revision of arthroplasty, either a total shoulder or hemi. So we'll talk more about on the irreparable massive cuff tear, whether to consider a reverse shoulder in such scenario or not. So my preferable algorithm to treat this kind of patient is, I usually consider, whether it is a traumatic or degenerative tear. So if there is a traumatic tear, I usually ask a patient to go for a ice application, analgesic and rehab for some time. So if they improve, I usually go with the continue conservative treatment. And if not improve, then the surgery. If the patient is a degenerative tear, I usually ask them to do a physiotherapy in form of muscle strengthening exercise, some activity modifications, and if they improve, we'll ask to continue the same treatment. But if they not improve, I ask them to go for a surgery. And in the surgery, now, whether the cuff is repairable or irreparable. So if the cuff is repairable, then do a repair, either single row, double row, go for a transosseous repair or the partial repair. If the cuff is irreparable, then there is again, either you go for a tendon transfer, SCR, tuberoplasty, balloon spacer, and at the end is a reverse shoulder arthroplasty. So how to choose this option among all these five? So the criteria for the reverse shoulder arthroplasty in irreparable massive cuff tear area without arthritis is painful shoulder, it's irreparable cuff, the pseudo paralysis, age is more than 65 and low demanding individual. So I usually follow these 5 points in my practice to go with the reverse shoulder arthroplasty in patient with a massive cuff tear without arthritis. So this is a good article from the JBGS. It's kind of first systemic review from the Mark Frankel group way back in 2010. They also concluded that the non-arthroplasty option is not viable for the rotator cuff tear. The RSA provides a reliable pain relief and return to shoulder function in patient with a massive cuff tear without arthritis. So they have studied this in 2010. So there is another meta-analysis from the JBGS in 2020. They studied that management of irreparable cuff tear without arthritis. This is a systemic review. So they concluded that the reoperation rate after physiotherapy is around 30%. After the partial repair is around 10%. If you do a tendon transfer or SCR in irreparable massive cuff, it's around 77%. But if you go with the RSR, reverse shoulder arthroplasty, is quite low among all these options. It's around only 8%. So these are another good paper from the reverse shoulder arthroplasty in massive cuff tear. Does the Ahmedabad classification affect the result or not? So they divided the patient in two groups, Ahmedabad grade 1, 2, 3. So it's without arthritis, and grade 4A, 4B and 5. So that is with arthritis. So they concluded that Ahmedabad classification did not influence the clinical outcomes or complication after the reverse shoulder arthroplasty. So there is a very recent paper from the 2025 from the Journal of Isacos. They also concluded that functional outcome improved in patient treated with the massive rotator cuff tear without arthritis. But the prior cuff repair failure was associated with the increased complication and revision rate. So this case is a 70-year lady. the right shoulder pain since last 2 years after the history of fall down, but not able to lift the shoulder since last 1 month. So she presented with the pseudo paralysis and pain since last 1 month in OPD. She is type 2 diabetic, night pain is present, range is very less, supra, infra is very big, subscape is good. So the pre-op X-ray, we can see there is no arthritic changes, no any proximal migration, and the MRI image, T2 coronal, you can see the cuff is very retracted up to the glenoid. Subscape looks good on the T2 axial. The T1 says the cuff atrophy is around grade 2. But the main problem is very retracted, massive retraction of the cuff beyond the glenoid, and the age is 70 and the patient is pseudo-paralytic. So we can see the painful pseudo-paralytic shoulder joint on the right side. So very painful. So I consider the reverse shoulder arthroplasty in such type of patient. As already mentioned, Kalpesh Trivedi sir, that the without arthritic massive cuff tear patient is very good patient to start with the reverse shoulder arthroplasty. So the pre-op planning, since the morning we are debating, you have heard about the blueprint software. So these are recently coming in India, the very good software. I have also learned this software way back in 2022 in the France, in the Senti group with the Gilles Walls and Nathan. So these are very good software. You can do all pre-op planning with the help of just DICOM images of CT scan. You have to just upload all the DICOM images on this blueprint software, and they give idea regarding the glenoid size and regarding the humeral size. So usually, as already we have mentioned that our patient is very small glenoid. So usually we prefer around 25 mm base plate, and on the glenosphere, I usually use a without lateralized glenoid. So it's a standard glenosphere, and you can see the central. They also give idea about the length of the central screw, 35 mm. So with the help of this blueprint software, you can plan your glenoid. So these are planning for the humeral. I usually consider 145 stem. The striker usually comes with the 135. So I use a 10-degree retentive and I make it 145. You can see it also gives the size of the humeral stem. Here they have mentioned around 2, but we'll see in the next slide that we have ended with the stem 1 size, because these are very small patient ladies, so it's very difficult to accommodate 2 or 3 size in such kind of patient. So these are, you can see the central screw. As Prathmesh sir has already mentioned that you have to feel the screw from the anterior aspect of the glenoid, not from the posterior aspect of the glenoid. That's why you can make it clear that you are in right direction with the help of glenoid version and everything. And the main crux of this surgery is this central screw, that is a glenoid. So I usually prefer deltopectoral approach. The first step after the deltopectoral release is the identification of biceps tendon. Usually I do a first tenotomy, and at the end we'll do a tenodesis. So the another step is subscape release. We have already seen 3 technique: peel off with the LT, or cut the tendon at 1 cm medial to the attachment for the end-to-end repair. Next step is the head dislocation with the capsular release with pec major release for the better external rotation. Then the humeral head cut. I usually prefer the humeral head cut in 30-degree retroversion. Now the glenoid exposure. The 360-degree rebular release is the key to see the whole glenoid and for the better exposure of the glenoid. So I usually start with the biceps, and from the biceps I usually go from the posterior to the anterior, and I complete the circle 360 for the labral release. And at the end you will get a good glenoid without any labral or capsular attachment. So now I usually prefer a 10-degree inferior inclination for the glenoid. Then we do a ream and we put a base plate around 25 mm. Now there is a humeral preparation. I usually prefer 30-degree retroversion. I use a 10-degree retentive poly for the better fit. So 135 plus 10, it makes is 145, and the final reduction. So the 1 month post-op shows a good inclination align of the screw in aspect of the scapular spine. So the take home message, the RSA remains the successful and well accepted treatment for the cuff tear arthropathy, but the management of this irreparable cuff with the help of reverse shoulder without arthritis is still controversial. But my indication is elderly patient, low demand individual, chronic irreparable cuff, pseudoparalytic with the pain. Thank you.
Thank you, Dr. Kaushal. Now we'll invite our next speaker, Dr. Nandan Rao, for his talk on tough glenoids in reverse shoulder arthroplasty. How do I ensure best bone resolution?
Good morning everyone. I'm Dr. Nandan Rao from Surat, and today I would be speaking on glenoid bone loss in reverse total shoulder arthroplasty, what it is and how to deal with it. So this is the agenda of my talk. So why does glenoid bone loss matter? What is the classification? What are the guidelines for management? Whether to do augments versus bone grafts, and finally a case of mine. So why glenoid bone loss matters? Because 39% of the cases have some or the other bone loss, whether significant or insignificant. They are more relevant in anatomical arthroplasty rather than in reverse, because reverse has been touted a way of managing glenoid bone loss. Cuff tear arthropathy mostly has a posterior superior bone loss, partly because most of the tears are posterior superior. So we should be concerned about two types of bone loss. One is the medial and other is the superior bone loss. Medial bone loss leads to an abnormally medialized prosthesis, notching, and it also leads to an abnormal deltoid lever arm. Superior bone loss leads to superior tilt of the glenosphere, a notching, and it also increases the shear forces between the glenoid and the base plate, and it is supposed to lead to instability because it is directly related to the superior tilt of the glenosphere. So classification, I'm sorry because my animations don't work that well on PPT. This was prepared on a keynote, so sometimes you will notice some discrepancy. So the glenoid bone loss might be posterior, which has been classified by Walsh. It can be a superior bone loss, which has been classified by Fawad. It can be anterior in cases of chronic instability, and it can be central in cases of inflammatory arthritis and primary OA. Will not go into the details of its classification. So this is the Walsh classification, and the other one is the Seaborg-Gupta classification, which has been modified by which has been modified from Antona et al. It is more useful in reverse situations, but you can use it for decision making in primary cases also. So these are the golden rules of managing glenoid bone loss. It has to be followed irrespective of the prosthesis you are using, but it can be changed partially depending on the type of prosthesis which you are using. So at least 50% of the glenoid base plate or the base plate bone graft composite has to rest on the native glenoid, preferably 2/3 or 75%. At least 50% of your peg or screw should be in the native glenoid. Minimum 2 of divergent screws, mostly the superior and inferior ones, should be present, and you have to preserve the subchondral bone. Once you ream the subchondral bone, you are going into danger territory of failure. With the striker system, you have to remember that the longest peg you will get is a 25 mm peg, and the screw which you will get is a 40 mm screw. So you have to plan accordingly with the type of glenoid and with the type of planning you get on your blueprint. So broad guidelines based on the percentage of bone loss, you have to get a CT, which is very essential. If you have a 15 degrees retroversion with a 8 mm bone loss, you can do what is known as eccentric reaming. Eccentric reaming is you ream on the opposite side of the bone loss to create a flat glenoid. Do not violate the subchondral bone in the process. If you have a 30 degrees retroversion with a 15 mm bone loss, you can do what is known as eccentric reaming along with an augment or a bone grafting, whichever you prefer. The augments, you have to remember that they give you they can compensate for 15 degrees and 8 mm of bone loss, and that is why First 15 degrees and 8 mm you manage with eccentric reaming, and the rest you can manage with an augment. If the bone loss is more than 15 mm, you have two choices: either do a bio-RSA, which I will speak later. This is the bio-RSA, or do a structural graft. Structural graft is you fashion it from the humeral head, fix onto the glenoid and put your RSA. And if the bone loss is more than 25 mm, and then you start becoming heroic with your surgery, is you start doing it with custom augments. With the Seaborg-Gupta classification, as long as the central defect is less than 50% of your glenoid with a stable vault, you can do a single stage reconstruction with bone grafting or augments. You have to remember that this striker prosthesis will give you around an 8 mm leeway with the central defects. The C3 is an C2 with unstable vault, and in these cases you can decide case wise, either do a 2-stage or a single stage with bone grafting and whatever you want. And with the last one, the C4 glenoids, you have to do an excision arthroplasty in Indian circumstances. With the eccentric defects, if it is less than 30% of the glenoid bone stock, you can still do a single stage reconstruction because you have a 15 degrees wedge which is available. And with the C3 glenoids, you have to decide again case wise, you will have to do a structural bone graft with fixation. And the last ones, the E4 ones, again excision arthroplasty. The caveat is there is no reliable method to determine the percentage of glenoid bone loss. The pre-op CT templating will help you with the seating of the glenoid component, and the bone graft can be either the humeral head, the iliac crest, or the allograft which you can get from the femoral head. Bone grafts versus augments. Now you have a bone loss, whether to use a bone graft or an augment is up to you, but there are some limitations to it. The glenoid augments, use of artificial augments, they give equivalent results to bone grafts, have a lesser complication, lower revision rate, they are easier to use, have a shorter surgical time, there are no problems with graft union, loosening or non-union. The disadvantages being there is an increased stress of the large metallic construct on the osteopenic bone. There might be peg or screw perforation, and sometimes failures can occur at the modular junction. Bone graft, this is not my video, but this is how you do a bio-RSA, which is the bony increased offset RSA. You take a piece of bone which is fashioned according to according to your pre-op template. You find out how the bone loss is. It can be centric, it can be eccentric, whatever. And the advantage is it is an autograft. The disadvantage is the entire prosthesis is resting on a bone graft which can resorb, and then you are reliant on the bony graft union and which can resorb and destabilize the prosthesis. So this is my case. So you have one case where you have a cuff tear arthropathy, then one doctor will come, he has shown RTSA for a massive cuff tear. Now I am going to the other indication, which is a patient with a primary OA, a degenerative cuff, which is torn partially. So this was a 65-year-old female, pain since 4 to 5 years. Her range of motion was 50% of her normal shoulder. There was primary OA of the shoulder, a tendinotic partially torn cuff, rotator cuff, a static posterior subluxation, which is again a contraindication for anatomicals, a B2 glenoid with superior bone loss, a retroversion of 16 degrees, a bone loss of 9 mm. That was a retroversion. So pre-op CT scan is a must. The medial border of the scapula should be visible to calculate the glenoid retroversion with the Friedman's line. The use of a planning software is very essential because then they give you the exact entry point, they give you the extent and exact position of the bone loss, the entry point and the direction of the guide wire placement, the extent of reaming, the direction of the augment if needed. For my case, it was a posterior superior augment, and size of the component needed, placement and length of the screws and peg. So this was her native anatomy. This was what was planned for her, and we had planned for a 74% seating, but it was more than that because I had overdreamed in this surgery. This was the post-op, and you can very well see how the augment has compensated for the superior and the posterior bone loss, and you have a very nice placement of the prosthesis, and functional outcome was fine. But the video is not working. Somehow. So the future is patient-specific instrumentation, where the prosthesis will be catered to according to the bone loss which your patient is having, custom implants, and intraoperative navigation. To end it, glenoid bone defects are quite common. CT scan is mandatory. Quantifying bone loss and plan appropriately, and judicious use of augments decreases morbidity. Thank you. Yes. So it depends on the CT templating, first of all. So if you see my case, you have a B2 glenoid. So you have a choice of reaming that B2 portion, or you have a choice of reaming the half of the glenoid. The advantage is with that half wedge, it will not sit perfectly, but with the full wedge, it sits, flush very nicely, and it is technically very difficult to do that half wedge carrying. They have a particular reamer which will ream it eccentrically. So with that, you get a full wedge and you can nicely place it.
Thank you, Dr. Nandan Rao. Now,
Dr. Manit has a question.
I can give you a complete contrary to this. So there is a concept where you're building up the augmented side to ensure that your glenoid becomes neutral. However, there is also a school of thought which says that अगर retroverted glenoid है, उसको retroversion में रहने दो. The reason being कि जो cases chronic होते हैं, so your soft tissues have adapted over a period of time to compensate for the retroversion. Now, when we try to correct retroversion and make a neutral glenoid, in fact, we're changing the entire soft tissue setting जो हमारी body ने की है, right? So I don't follow it, but there's a complete school of thought which also says कि if retroverted, implant also in retroversion and allow the soft tissues to breathe, or if you're completely go to the other school of thought which says कि bring it back to neutral, and then your soft tissues will compensate over a period of time. What do you do? Which one do you follow?
So I did not get into the details of this case because I had to fit it into a time slot. So the lady's first complaint was her limited range of movement. And the second thing which she was always complaining was a posterior scapulothoracic pain near the medial border of her scapula. I knew with the rotator, with this RTSA, I could compensate, I could get her range of movement back. But what was wrong was her altered scapulothoracic dynamics. So I thought this fixed posterior subluxation was somehow not, I could not, give her that posterior scapulothoracic. Maybe with the RTSA, the scapulothoracic dynamics would have improved and she would have improved on her pain in the medial border of her scapula. But somehow at that point of time, that was my thought process. Let me bring this back to a very anatomical position, and then probably that medial scapulothoracic pain might go off. So that was entirely what you might say, not very scientific, but this was the thought process behind doing this wedge, bringing it back all together into a normal position.
Do you prefer to do some bone grafting or do you prefer metal backed augmentation?
Sorry?
Do you prefer to do some bone grafting? See, if you've got a B2 or a B3
yes,
or a C glenoid.
B3 and all I have not handled, I have gone up till B2.
So if you wanted to bring it back to neutral, say you're of that school of thought, I want neutrality only in my life, right? So if you want to bring it back to neutral, so would you ever consider that maybe I should just do a little bit of grafting here? Because the problem with these augmented wedges over a period of time, they've actually shown to have less result than doing bone grafting. The contrary to bone grafting, of course, is now you've got two interfaces of healing. Your healing needs to happen from metal to the bone graft and from bone graft to your host bone.
Yes.
Right? So you have if your bone graft does not heal, then you have a floating prosthesis.
So I have not done a bone grafting for this. So basically the idea is with that porous material, the tantalum porous material, I have just reamed and exposed the subchondral bone. and we are believing that it will biointegrate into the prosthesis. Putting a bone graft on the posterior side, impacting a glenosphere, first of all, technically very difficult. I don't want the bone graft dislodging out of there, going into the inferior axillary pouch and causing all sorts of synovitis and problems. So if I have to bone graft, the bone graft has to be there in a very fixed position. With that bone grafting, my pre-op planning, there was a 16 degrees of
Bone grafts will never cause synovitis. So
I believe you are talking about the cancellous bone grafting.
yes. So because you've already cut the head, so you have the bone graft with you.
Yes.
Yeah.
No, I'm talking of the cancellous bone graft dislodging between the interface of this. Sometimes maybe. So already you have an open bone surface over there. You have a tantalum prosthesis which is going and impacting and sitting there very nicely. So I don't feel the need to bone graft at that interface again.
Okay, thank you, Dr. Nandan Rao. We'll move ahead and take question answers later on. The next speaker, Dr. Dromil Patel, and he will focus on the role of lateralization in revision.
All right, good morning. Thank you, Prathmesh sir, for the invite. Very nice meeting. One message that I want to tell is that maximum reverses that I have done personally are for fractures. And believe me, exposing a glenoid in a fracture scenario is far easy as compared